Moving on to the next presentation is on approach to congenital and developmental glaucoma by Dr. Anil K. Mandal.
This is forward. Thank you for the opportunity. Dignitaries in the dais, friends, ladies and gentlemen. I have been asked to keep my presentation very basic, particularly for postgraduate students. So it will be very basic, approach to congenital and developmental glaucoma. The typical presentation is seen here. Congenital glaucoma is a rare disease, but it's a disease which occurs worldwide. Its prevalence has been reported to be 1 in 10,000 to 1 in 30,000 live births in the Western population. But a population-based study from India revealed that our prevalence in India is 1 in 3,300 live births. So we have a disease which is about, I'll say, 8 to 10 times more common than the Western counterpart. Congenital glaucoma is primarily a surgical disease, but surgery should be done at an early age as possible. That doesn't mean that we can send the patient directly from OPD to surgical room. No. Well-established methods should be applied to establish the diagnosis, rule out the other possibilities, and then plan for surgery. Now, it is basically related to trabecular dysgenesis, which may be associated with iridodygenesis and corneodysgenesis. Classic triad is epiphora, photophobia, and blepharospasm. And an initial examination in the office is mandatory, and in cases where examination under anesthesia is required, we should be able to do the examination and establish the diagnosis. We should proceed with a very meticulous and detailed method of evaluation under anesthesia, and proper equipment should be available like ultrasound evaluation, UVM, etc. And these are the differential diagnoses when conditions are associated with epiphora, blepharospasm, and photophobia. This is primary and some pictures of secondary developmental glaucoma. And when we come across, this is a very well publicized and well paper published to remember the differential diagnosis. I'll come to some differential diagnosis. This is a patient who was referred to us 2 hours after birth with a note that the patient is having unilateral congenital glaucoma, referred by an obstetrician who delivered the child. But, forceps application were there, and actually it is a case of birth injury mimicking primary congenital glaucoma. The disease appears to be more common in the left side because of LOA position of the presenting part. The other differential diagnosis may be CHED. In isolated cases, the ground glass appearance is very classic, and most important differentiating feature is normal intraocular pressure, but very high corneal thickness. That is the thing. Some syndromes like mucopolysaccharidosis can present with hazy cornea, and we'll have to establish the diagnosis. Axial length, megalocornea, anterior megalophthalmos should be differentiated. Typical HAPS-TRI is seen here, and the anterior segment OCD picture of HAPS-TRI is seen here. Corneal dimensions should be measured, refraction should be done, tonometry should be done, and we'll have to do a detailed evaluation of the anterior segment with the help of slit lamp or under operating microscope. Gonioscopy should be done, but a significant percentage of patients will not be suitable for gonioscopy in our patient population because some of the patients will present with very severe degree of corneal edema, where gonioscopy and ophthalmoscopy is not possible. Ultrasound evaluation should be done. Here is a patient, there was total retinal detachment along with congenital glaucoma, and here is a patient who had posterior dislocation of the crystalline lens. Here is anterior dislocation of the crystalline lens. A very important diagnosis. The patient was referred with the history of typical feature of congenital glaucoma, but actually it was a case of posterior segment pathology. That's a ultrasound B scan revealed hyperechoic intraocular mass and diagnosed to be having retinoblastoma. Must be differentiated before we really plan for the management. And here is a patient, typical bilateral appearance, and ultrasound biomicroscopy revealed that there were iris cyst and secondary developmental glaucoma. So all these things should be evaluated before we really plan for management. When isolated trabecular dysgenesis is presenting with primary congenital glaucoma, the diagnosis is established and surgical treatment should be planned at an early age as possible. It may be associated with several other developmental abnormalities of the anterior segment. Is an important consideration. Corneal clarity, corneal diameter, and severity of glaucoma is an important consideration for the surgical approach we do. Most of the patients we see in India, we manage with primary combined trabeculotomy and trabeculectomy. I'll present a surgical video on that. Can you present the second part of the presentation? Yeah. So here is a typical case of bilateral primary congenital glaucoma. Now the question comes, what is the best primary surgical treatment? Because the first surgical treatment or the initial surgical treatment has the best opportunity for better outcome. Advanced cases may be there, and here is a situation, very advanced case of congenital glaucoma. When we inquire the history of surgery for primary congenital glaucoma, before 1938 there was no surgery described. The ultimate effect is blindness. But if we consider 1938 onwards till date, about 86 years history of surgery for congenital glaucoma. Started with goniotomy, trabeculotomy ab externo, primary trabeculectomy, combined trabeculotomy, trabeculectomy. A very important advancement came recently in the year 2010, fiber optic microcatheter trabeculotomy. And we, in the year 2022, improved the surgical technique for a special set of subset that is advanced case of neonatal onset primary congenital glaucoma, where illuminated microcatheter passage assisted circumferential trabeculotomy was combined with trabeculectomy. I'll present the video on that. When Barkan reported his case in the year 1938, authorities from all over the world visited him, learned from him, like Robert Schaeffer, Arthur Lister visited him and came back to Arthur Lister was from Moorfields, started the work in Moorfields in the year 1950s. Professor Sood, my mentor, did his FRCS in Moorfields in early 60s and learned the technique. Came back to India, started the technique. I learned the technique from Professor Sood. I'll come to the presentation, primary combined trabeculotomy and trabeculectomy in a separate video. I'm just presenting this case.
Incision is then made across the scleral spot.
Can we improve the sound? Yes, yes. Sound is there. Anyway, other videos are there, I'll come to it. So this is a patient of infantile onset congenital glaucoma of the left eye, and the patient came into the emergency. We diagnosed, operated on the left eye in the very next day, and you can see how dramatically the condition has improved over time. Can you present the sound also?
With appealing eyes, he speaks the language of his soul. The faces lit up with smiles, a radiant beam on the baby's face. not a patient, but like my own child does seem. These little gems are tomorrow's dreams. I cherish their budding beam.
So here is the photo essay presented in New England Journal of Medicine long ago. Here is the patient at the age of 10 years. So, you know, the outcome may be so good that here is a child at the age of 11 months after simultaneous bilateral surgery at second month of birth and dancing here. So I'll skip some of the slides here. We presented a series of 1128 eyes of 653 consecutive children done over a period of 21 years. The results are good. And here is a patient, 220 eyes of first 121 patients over a period of first decade, that is 1990 to 2000, who completed at least 21 years of follow-up. Here is a patient who completed 27 years of follow-up and is doing very well. A patient who completed 30 years of follow-up, and here is our results. According to last count, 13 of my operated patients are dentists, 7 did PhD, 11 are doctors, medical doctor, of which 8 did postgraduate medicine. Several patients are teachers, engineers, lawyers, journalism, chartered accountant, and self-employed. I am presenting the new surgical technique. Watch this surgical technique. Sound is there. Can you present the sound?
A drop of viscoelastic material was placed in the opening of the Slem's canal. 2 time forceps were used to grasp the illuminated microcatheter, placing the tip in alignment with the canal, and the device was advanced into the canal. The lighted tip allowed for the surgeon to visualize the cannulation of Slem's canal for 360 degrees as the catheter was advanced. The catheter was grasped with a forceps when it emerged from the distal end of the canal and was pulled out a little bit. Both the exposed ends of the catheter were pulled in opposite directions using a tangential force like a purse string, thus garroting all 360 degrees of the trabecular mesoneum. With the help of Vanna's scissors, the 2 by 2 millimeter trabeculectomy block was removed and an iridectomy was then made. A subconjunctival injection of 0.3 ml of dexamethasone was given in the inferior fornix. A poorly functioning distal outflow pathway will necessitate an additional surgical step that bypasses it, like trabeculectomy. This surgical procedure actually represents a microcatheter-assisted, novel, distinctly advanced, luminous technique, that is, MANDAL technique, suitable for advanced primary congenital glaucoma.
Just 2 more minutes, an edited video of primary congenital glaucoma done on a patient whose both the parents were blind because of primary congenital glaucoma.
Congenital glaucoma. Simultaneous bilateral primary combined trabeculotomy and trabeculectomy was performed on this baby at the age of 3 weeks when the body weight of the baby was 1200 grams. Compare and contrast the preoperative and the 3 weeks postoperative appearance of the baby. At 6 weeks postoperative, the child had total clearance of corneal edema in both eyes and the bleb appearance was satisfactory. The child is enjoying age-appropriate normal visual acuity in both eyes and the activity of the child is normal and the parents are extremely happy with the surgical outcome.
दो साल पहले मेरे बच्चे का ऑपरेशन इसी अस्पताल में हमने किया था जिसका नाम स्वर्णम है। आज वो 2 साल का हो गया है। ऑपरेशन इतना सक्सेसफुल रहेगा हमें उम्मीद नहीं थी, पर आज हमारा बच्चा हमारा कैसा सहारा बन रहा है आप भी देख सकते हो। कहीं पे भी मेरा बच्चा हमें हाथ पकड़ के लेके जाता है। ऐसा लगता है ये लकड़ी की ज़रूरत अभी 1 साल और रहेगी। 1 साल के बाद में अगर वो पूरा समझने लग जाएगा तो हमें ये लकड़ी की भी ज़रूरत नहीं रहेगी। हमारी लकड़ी हमारा बच्चा ही बन गया है। ऑपरेशन बहुत सक्सेसफुल रहा। आज हमारे बच्चे की हमको बहुत मदद होती है। घर में कोई बर्तन घूम जाता है तो बर्तन हमें ढूंढ के देता है। आज बच्चा देख सकता है तो हमें कितना खुशी होता होगा। आपको हम हमारी खुशी शब्दों में बयां नहीं कर पाएंगे। मैं मेरा पूरा परिवार रेलवे प्रसाद अस्पताल का बहुत बहुत शुक्रगुजार हूँ। विशेषतः मंडल सर और उनकी पूरी टीम का बहुत बहुत शुक्रगुजार हूँ।
Thank you. The child completed 4 years of follow-up. This is the last photograph taken about a month ago.